I would like to introduce Dr. Deodutta, Director and Consultant Nephrologist, Supreme Kidney Care, Nasik, and Professor of Medicine from Pawar Medical College, Nasik. Um, he was the ex-president of Indian Society of Nephrology West Zone Chapter um, and Indian Society of Critical Care Medicine, Nasik Chapter. Uh, we are happy to have you, sir. Over to you, sir.
Thank you. Thank you for the invitation. It's difficult to follow an oration talk by Narayan. And of course, I am also aware that this is a pre-lunch session. And a lot of things in my talk have already been discussed in the previous sessions regarding the practical aspects of CKD nutrition. So what I was told to do is to talk about KDIGO 2024 nutritional updates, and almost all speakers prior to me, they have referred to the KDIGO guidelines, and I would like to give you some newer information as far as this is concerned. Now, as far as CKD nutrition is concerned, there are three main things which the KDIGO has talked about recently. One is a plant-based focus, because there is a greater emphasis on that. Second is there is something called as protein refinement. We are talking about quantity of protein, we are talking about quality of protein, but we must talk about protein refinement, that means individualization. And then the KDIGO has also talked about the sodium targets. Now, as far as the progression of chronic kidney disease is concerned, remember that we have to reduce protein energy wasting as well as metabolic complications, and that is one of the goals of nutrition therapy. So we have to optimize, I think this word was used in the last talk also, that we have to optimize nutrition. And you can do optimization by various methods. One is of course physical activity besides the drug therapy, and then the diet. And the diet has got so many constituents. So these are the tools which have already been discussed, and KDIGO has said that you can use all these tools as far as assessment is concerned. And the KDIGO guidelines have emphasized all the time that assessment with validated tools is very, very important for malnutrition, because your pendulum can go from this way to that way, and then because of over restriction, you might land up with protein energy wasting. So this is one study which we had carried out in our institute, where we compared the various tools and SGA versus MIS. And in our population, we found that in our dialysis patients, when we compared the methods of assessment of nutrition, we found that the SGA tool was better as compared to the MIS, because it was more practical and very easy to handle. So how do you optimize nutritional care in patients of CKD? One is that of course you have to convince the patients for compliance, and then the importance of nutritionists and dietitians cannot be overemphasized, and you should propose a food which is adapted for the CKD patient. Again, this was talked in the debate. So what is the ideal diet? So nutrition can be multifaceted. So this is one interesting study which I found, that how much difference can you make with various parameters which you can alter. For example, physical activity, sodium, and vegetables in the diet. So here you can see that there is a definite reduction in the incidence of chronic kidney disease with vegetables as well as physical activity. So it is protective in nature. As far as GFR decline is concerned, again a vegetable diet is better as compared to the others. So here you can use all these parameters individually to every patient and then try and find out how the patient behaves. Another thing which I found in the literature is about dietary supplements. And here you can see the prevalence of dietary supplements vis-a-vis the incidence of CKD. And here you can see that if you have there are 3 models which they have used in this trial, and what they have found is that if you have amino acids and proteins as mentioned here, the incidence of CKD might be worse, and vitamins and minerals also is high on the list. KDIGO has talked about ultra processed foods and the incidence of CKD. So therefore, one has to be very careful about ultra processed foods, and this has to be emphasized. So if you look at the various nutrition guidelines in patients of CKD right from 2000 up till now, there are many changes which have occurred, and many guidelines have said many things. So, but as Dr. Umesh Khanna mentioned in the morning, 2 or 3 things have not changed over a period of time. The comment on proteins have not changed over a period of time. Of course, the nuances of protein therapy or protein restriction have changed, and we are becoming more individual as far as the protein recommendations are concerned. The salt recommendations have also not really changed over a period of time. So if you talk of the KDOKI guidelines, then these are the highlights which I can mention. One is the adequate energy intake, which is 25 to 30 kilocalories per kg per day. Proteins to the tune of 0.6 to 0.8 grams, and which is LPD. LPD can be lower than that. And of course, keto analog supplementation has already been talked about. One more important thing which the KDIGO has said is fibers. 50 to 70% of fiber should be of plant-based origin. Potassium less than 4 grams, and I would like to elaborate about the potassium part because everybody talks of hyperkalemia, and then the salt. And this slide was also shown in the morning about how do proteins affect the intraglomerular pressure and why low protein diet is important for renal preservation over a longer period of time. And therefore, if you talk of the protein intake and uremic toxins, I think a lot of literature has already been discussed about what happens to the protein degradation products like indoxyl sulfate, and then how they are harmful as far as the kidney is concerned. So, a lot of evidence is there regarding the reduced protein intake from various observational studies, and a meta-analysis of all these studies has also shown that you can compare a VLPD, which is 0.3 to 0.4 gram per kg, plus keto analogs, and compare it with the LPD, which is 0.5 to 0.6 gram per kg. But the debate is far from over. There are many statements in the literature where they have said that you cannot restrict proteins, whatever has been recommended. So these are some of the statements which I am trying to show here, that it is wrong to restrict proteins. So the summary is that you have to optimize, you have to use moderation, and you have to individualize. Again, this was mentioned in the morning, vegetarian diet is not associated with a low muscle mass. So just because you don't eat meat, that does not mean that you are going to be having a very poor muscle mass. Now, the other nutrition, this is a French study, other nutritional parameters, again what they have tried to show here is that if you restrict proteins, the muscle is recycled over a period of time. So just because you are advising a diet, and that to a plant-based or vegetarian diet, that does not mean that you will be malnourished over a period of time, because there is muscle recycling which occurs, and in fact in some patients 85% of the muscle is recycled, and therefore you don't really develop malnutrition just because you take a vegetarian diet. Now, the second important point which KDIGO has said is that we have talked about the quantity of proteins. What about the quality of proteins? So, quality is of course animal protein versus plant proteins has already been discussed. But an example of the quality of protein would be if you decrease only the aromatic amino acids in the proteins, then what happens to the renal fibrosis and the uremic toxins. So, you can have lot of nuances as far as protein intake is concerned. Within the protein environment, you can have many extra issues which you can discuss. For example, aromatic amino acids, or you can increase only the sulfur containing amino acids like methionine and cysteine, and again have some beneficial effect. Again, this is a study which was published some time ago. So, as far as protein intake is concerned, there are refined recommendations. Standard protein intake has been defined. Avoidance of high protein diet, you have a very low protein option, and you have to individualize, and of course you have to balance the diet. So protein type, I think we had a big debate as far as plant versus animal, so I am not going to talk about it much because a lot of information has already been shared. There are some advantages of the plant-based diet, and we already voted as far as the BIGS diet is concerned. So there are different types of plant-based diets. One is a DASH diet. You can have a Mediterranean diet, a flexitarian diet, or a MIND diet, and of course there are many others also which Dr. Nayak mentioned about the Play-Doh diet. Now, as far as progression is concerned, this is a paper from C. Jason. What is the association between plant-based diets, incident CKD and kidney function decline? And here they said that if you have a higher adherence to a healthy plant-based diet and a vegetarian diet was associated with a favorable kidney disease outcome. So again, you have to favor the plant-based foods, and the rationale is that you improve the nutrient density, reduce the dietary acid load, anti-inflammatory effects of plant-based diets, and the lower phosphorus and potassium bioavailability. Some comment about the role of gut microbiota, which is very important in our practice. We know that probiotics, they reduce the inflammation. So this is one illustrative study which has shown that if you use ordinary yogurt, even that reduces inflammation, and if you use probiotics in addition, again that also reduces inflammation. Fibers have a positive role, and there is a direct correlation between fibers and mortality in patients of chronic kidney disease. So we have to be very, very pragmatic about advising patients about use of fibers, and here we have said what is the how are fibers very, very essential and how they are useful. As far as potassium is concerned, now it's time to be more flexible. That is what Deodutta is saying. We should not be obsessed about the risk of hyperkalemia, and this is a meta-analysis of correlation between serum potassium and the estimated potassium intake and the mortality. So they have tried to estimate the 24 hours urinary sodium and potassium excretion and the cardiovascular risk and the effect of salt substitution. So here what they said was low dietary potassium increases salt sensitivity by increasing the activity of thiazide sensitive sodium chloride cotransporter in the DCT, and this acts as a potassium sensor. So basically what they are trying to say is that again, do not be over cautious about hyperkalemia, because there are some studies to show that there is no association between gross hyperkalemia and the progression of CKD. Of course, you have to look at the cardiovascular component of high potassium, but remember that higher urinary potassium excretion was associated with a lower mortality. So optimizing potassium is also important, and not getting over obsessed by hyperkalemia risk is also very, very important. And the last point in the Deodutta is the sodium intake, which is the critical target, less than 5 grams and less than 2 grams, which is the sodium equivalent. And these are the practical recommendations for patients as far as the sodium intake is concerned: vegetables and fruits, whole grains, legumes, nuts and seeds. And then sarcopenia has already been discussed. There are a lot of problems related to sarcopenia, and we have to really try and find out how our patients are doing. This is one study which we recently presented in the World Congress at Tokyo. The effect of intradialytic exercise to reduce sarcopenia in patients on dialysis, and this was a positive study as per the literature. Now this is a very interesting French study which I came across, and what they have tried to do is that how do you convince your patients? So if you have a consultation as far as diet is concerned 1 to 2 times per year versus virtual consultation or a flash consultation or an e-consultation, or you can have an educational program. So there are many ways by which you can put your point as far as practical experience is concerned. And it takes time to modify nutritional habits. So in this particular French publication, they found that over a period of time, an omnivorous patient, he changed to flexitarian first. That means he became more flexible as far as diet is concerned, and then he became vegetarian over a period of time because probably he got convinced over a period of time. So advocacy is very, very important. So you cannot do it without nutritionist or dietitian, and of course offer different consultation modalities to provide nutritional advice. So diet planning is very important, and beyond diet there is a holistic approach in addition to the diet which has been mentioned here. So as far as the KDIGO highlights are concerned, these are the key dietary modifications for CKD management. One is focus on plant-based nutrition. Proteins, the advocacy is about the right balance of proteins in the right patient. Sodium, less is more. Nutritional counseling is very important. Potassium should be a customized management, and do not be obsessed about hyperkalemia all the time. It should be, there is some advice which is tailored for all, but there is some advice which is not tailored for all, which is individualized. And then there is something called as a Mediterranean marvel, where you can have advice regarding the Mediterranean diet. So these are the key takeaways as far as the KDIGO the guidelines are concerned. And lastly, the NIN dietary guidelines are very important because this is what is important for us in our country. And we know that NIN is a premier institute. So in the Indian subcontinent, how do you apply the KDIGO guidelines? Because we have so many diverse food habits, we have different cooking oil choices, we have sources of animal proteins which are different, and we have a 365 days festive culture across seasons and across regions, and therefore having a dietary advice is very, very diverse as far as India is concerned. So our problems are more complex as compared to the standard guidelines. So this is a publication from the NIN, just for your information, about glycemic index and all our culinary dishes, and this is also one more publication regarding the nutrient rich choices, recommended vegetables versus recommended fruits. So the ICMR India guidelines have told us about guidelines for CKD prevention in India, and there are some practical steps as far as prevention and management are concerned. For CKD patients, you must personalize the dietary plans, careful consideration of local food staples, and regular monitoring of renal parameters. And if you have a professional guidance and individualized care, probably you are going to get 100% result. So therefore you have to bridge your Indian data with the global guidelines. You cannot just follow the global guidelines, and that is your pathway to a better kidney health. Thank you very much for your attention.
Thank you, Dr. Chafekar. That was an excellent, practical, very useful presentation. So before we chairpersons give our own comments, I would like to open the topic to the floor for any questions. Fine. So before the audience comes up with their questions, again I would congratulate you for the excellent presentation. And what I understood is there has been evaluation in the principles of diet in CKD. Like as students, KDIGO 2012, we were more restrictive. Protein was restrictive, potassium was restrictive. Then we had KDOKI 2020 when we were teachers, and we had more numbers to deal with. This much protein, this much potassium, so on and so forth. Whereas this diet, what you have highlighted, is more practical, plant-based and personalized. So I think it's moved away from potassium restriction. The protein has become more liberal and it focuses on the holistic approach. My question to you would be, what would you envision changes going down the future? Because we have a lot of subsequent studies after the KDIGO 2024 as well. So what might change in the future?
So I believe that we need to Indianize the Western guidelines or the KDIGO guidelines. So we are making some attempt in one of the nutrition societies to Indianize each guideline. So for example, if you're talking about proteins, then we need to profile our patients properly, and then probably individualize the protein, not only the targets as far as the number is concerned, but also the assessment tools and the frequency of assessment. One mistake which we make is we don't assess the patients more frequently. We do it maybe once in a year or something like that. So therefore, what I envisage is that in the future, we need to Indianize the Western guidelines, number one. We will become more flexible and we should have a more patient-friendly approach as compared to a restrictive approach which you have already mentioned.
Yeah, so before I hand over to the other chairpersons, so one thing would be, I mean, this 2024 diet doesn't mention anything about the gut microbiome. As of now, nothing much is there. And it doesn't mention much about the CKM, holistic phenotype, which Dr. Narayan did discuss. And in this, it gives Plado diet as a suggestion, not a recommendation. So going forward, do you think that Plado would be a recommendation and more than 70% plant protein and all would be a viable option?
Though it can be a recommendation, I think that ultimately individualization is the key. So in general, probably it is possible to recommend to the patient in general. But however, to follow to follow any diet for that matter, you need a lot of exchanges all the time. So unless you give exchanges to the patient, you are not really going to make the diet more interesting. So we can talk of different diets, but to follow any diet for years together is going to be very difficult. So we need to have innovative strategies to make it more interesting.
Yeah, we have a question there. Please go ahead.
Sir, I'm Dr. Piyali Sarkar from Kolkata, and I have two questions. So these are very thought-provoking ideas, and they really stimulate us to think. And my thoughts are, sir, regarding the alpha keto analogs, low protein diet plus alpha keto analogs, compared to the use of pre-probiotics. So do you think there's any advantage towards using any one of them, or what would you recommend? Because I use a lot of pre-probiotics and I have found good results with them.
I don't think that they are either or. So they are different. I mean, the mechanisms of keto analogs and the advantages of keto analogs are different as compared to the pre and probiotics. Now, ultimately, what you are going to achieve is slowing the progression of chronic kidney disease. So to my mind, in the future, it is going to be additive and not instead of each other. So one cannot have a situation where you will use only keto analogs and then try and find out whether the patient is doing well, or you will use only pre and probiotics and then try and find out whether the patient is doing well. In fact, many of my patients could be on both, and then we try and get a better result, because the advantages of keto analogs are related to metabolic acidosis and other things. As far as pre and probiotics is concerned, it is more related to the excretion of toxins.
So actually it's a factor of cost, because both of these medicines are quite costly, and when the patients pay out of their pockets, it's very difficult to convince them to take both of them. So that makes the choice. And the second is that we are emphasizing on the Mediterranean diet. So Mediterranean diet, we are saying that it's a vegetable-based diet. But the vegetable-based diet in the Mediterranean food and that of the vegetarian-based diet in Indian food is completely different, because they mostly depend on salads, on green vegetables, and they don't use a lot of masala. But in Indian context, when we use vegetables, most of it is cooked or boiled and put a lot of masala along with it. So at the end of it, if we derive the true, benefit of vegetarian diet, that is a big question mark, because most of the Indian society, as we know, are dependent on the vegetarian diet. But however, we don't see any less occurrence of CKD in our population. That's my observation. Thank you, sir.
Yeah, so I agree with your point. So we have to make our diet more palatable, and we have to Indianize the recommendation. So we cannot just follow the Western recommendation as it is, because it's very difficult to follow that diet. But ultimately, some attempt has to be made by everybody to, with the help of dietitians, to make some recipes which are acceptable to our population And it can be done zone wise, because north eats something different, south is something different, east and west are different. So therefore, we have to have zone wise probably recommendations and then take it forward.
A very wholesome and very well summarized talk, sir. I hope the society SRNM comes up with Indian guidelines probably by next year conference, and once we come up with Indian guidelines, later we can, as you said, we can diversify into South Indian, North Indian, because as you said, Indian culinary is very vast and diverse. So people, the patients specifically ask, can we add this? Can we add this? So we, we need to check again. So I hope by next year the society comes up with Indian guidelines for CKD diet. Thank you, sir, for a very well summarized talk.
I want to.
Yeah, please go ahead.
Even for the med diet, as we were discussing about, we need to suggest the Indianized version of the Mediterranean diet, like olive oils we can replace with the mustard oil, which is having a very good amount of MUFA, and it is also having an ideal ratio of N6 to N3 fatty acids, and it is also having a very good high smoke point as compared to olive oil, which is having a very low smoke point. And Indian culinary practice, we are using cooking things at a very high temperature. We are not using the olive oil for the salad dressing. So med diet is good, but we need to tune it with the Indian population.
Thank you. Great suggestion. Any comments? Yeah.
Thank you, sir, for the amazing presentation. I strongly agree with you that Indian diet, especially like in cities like Hyderabad, if we see 10 patients, their diet is completely different. 10 people have 10 different kinds of diet, and it should be individualized, with salt restriction being the key factor. Thank you for the amazing presentation.
So just one last thing I would like to say, sir, like you talked about SRNM coming up with new guidelines. I think we have plenty of guidelines, but one step forward by the society could be implementation of these guidelines. So maybe use of AI. So the patient just puts the tool and then the content comes on their cell phone. The digital diet therapy by SRNM, that would be one thing, because it would be catchy and very practically useful. The other thing could be, we all talk about protein, not restricting, all those things, but we all know that it's never implemented in clinical practice. So probably more noise on the social media. The dietitians are educated, the nutritionists are educated, the nephrologists are educated, but what's not happening is it's not translating into practice. So maybe the second point could be that we popularize, don't restrict plant protein on social media. That may be a Facebook or any other sort of platform. So those two goals, I would think, digitalize, use AI in implementing, so that the patient also is able to pick up what he's eating and what's wrong or right for him. And the second thing is popularize this on social media. The key points maybe.
The only point about AI is that it should be supervised.
Yes, absolutely.
Because the AI something gives the recommendations which are probably not correct. So it has to be supervised by the doctor, the nephrologist and the dietitian, so that the AI recommendations can be followed.
Thank you very much. Yes.